So like I said, welcome everyone. And I'm going to try and share my slides, if I can work out how. So again, welcome, and we look forward to learning together. So we'll go through a bit of housekeeping. Please keep your mics on mute while the session is going on, unless you're speaking. This session is being recorded, so if you don't wish for your face to show on the screen, please, you can leave your camera off, and also you can try and use the chat instead of speaking. Please use the chat box for any question, and please keep your phones or devices on silent during the session. Grab yourself a drink before we start, and if you need any help with Zoom functionality during the session, please contact agile.educationofficer@gmail.com.
Thank you very much. That's so overlapped it.
So, before the session starts,
thank you much, please.
We'll do a quick mute yourselves. That would help, please. So I'll do a quick plug. So Agile, like I said, is a professional network for physiotherapists and other colleagues who are interested in working with older people. There's more information on our website. There are lots of benefits of joining Agile, just like other professional networks, and they are on this slide. So please do join if you're not yet a member. It costs about £25 for the whole year. That's the membership fee. And for students, it's £5 per year. And students can pay for the whole 3 years of their course. That's £15. We have some vacancies on our committees. Please, if you're interested, do get in touch. And we always have places on the regional committees. So if you're not sure about joining the national committee, please, you can join the regional committee and get used to that. And yeah, just get a hang of things before you dive into the hard work, if I may say that. So our speaker today is Jackie Holmes. She's a senior physiotherapist and she's the team lead for the healthcare of older people at the Queen Elizabeth Hospital in Birmingham. So Jackie has done a lot of work around integrating deconditioning in the inpatient setting, and she has taken part in the national reconditioning program, the reconditioning games. So I will invite Jackie to speak to us now. She will tell us a bit more about herself and a bit more about the work she's been doing. And we will have some questions later. She'll be able to answer some questions after her talk. So Jackie, over to you.
Lovely, thank you so much. Let me just try and share my screen. Okay. Can people see this?
Yes, we can, Jackie.
Yeah. Well, lovely. So yeah, thank you so much for inviting me to speak on tonight's webinar, and thank you for those that have joined this evening to spend a bit of time talking about reconditioning and some of the things that we're doing in Queen Elizabeth Hospital, healthcare of older people. Hopefully try and sort of inspire some of you on the call to start implementing some changes or consider how you can implement some changes to try and prevent hospital-acquired deconditioning in your setting. So as we say, my name's Jackie. I'm a senior physio and team lead for healthcare of older people at the Queen Elizabeth Birmingham Hospital. And in today's talk, we'll just touch on what our mission to recondition the nation is, why it's so important, how we've gone about trying to achieve that mission, how we're trying to sort of spread the word and our next steps, and then just give you some sort of top tips to take away with regards to trying to implement these changes in your setting. So where did it all begin? Last September, I attended a British Geriatric Society conference on falls and postural stability. And during that, there was a workshop that was run by Dr. Amit Arora and Professor Dawn Skelton. And it was all around preventing inpatient deconditioning, trying to sort of inspire us to consider a simple idea to take away and implement in our work. So this led to me coming up with this kind of concept of a movement board, which would be placed behind patients' bed spaces. And on this, there would be a tick list of activities and functional things that patients could feel empowered to tick off during the day to say that they'd achieved them. And the idea was that it would kind of be a talking point for staff and visitors to ask patients who are in hospital, have you got out of bed today? Have you sat out for your meals? Are you going to the bathroom? Have you done any exercises? To try and get them to sort of tick these things off and bring it to the forefront of their minds as part of their recovery whilst in hospital. I shared this kind of idea on Twitter, and it got a lot of kind of positive feedback, constructive feedback, and it caught the attention again of then Dr. Amit Arora, who is part of the emergency care improvement support team. And it was through these interactions that I then found out about the National Reconditioning Games, which was an initiative from the Emergency Care Improvement Support Team, or ESIST. And they launched this National Reconditioning Games initiative in November. So some of the main purposes of this initiative were to raise awareness of deconditioning in health and care settings, maintain a focus on kind of reducing hospital length of stay, but also to address kind of moral injury that staff are facing in the acute settings and in the community. And it was also encouraging teams to submit medal applications to recognise and celebrate some of the activities and progress that were being made. And that fell into 3 different categories. So making a difference, supporting people to keep moving, and supporting staff to keep active and well. So when this was launched, I was really excited by this project and appreciated its importance in trying to get people, both patients and staff members, kind of engaging in activity again, engaging in social and physical well-being as we came out of the pandemic. I especially like the fact that the focus was on taking sort of small steps and implementing small changes to reduce the harms of deconditioning. So there wasn't this overwhelming sense of, I must implement this project, I must achieve this, I must do this. It felt quite achievable, it felt quite fun, and it was quite positive. So it was something I knew that we could work on in the Queen Elizabeth Hospital as part of healthcare of older people, to really improve care for our patients. So with that, all our staff pledged to recondition the nation in November last year. So just quickly why it's so important, and we'll touch on deconditioning. So deconditioning is the condition of physical, psychological and functional decline that occurs as a result of the complex physiological changes induced by prolonged bed rest and associated with loss of muscle strength. And we know that patients in hospital are very sedentary, and alongside their accompanying illnesses, this predisposes older people to deconditioning syndrome, the effects of which can be far more rapid, far more severe, and sometimes irreversible due to frailty and a decreased bodily reserve in older adults. So we all know that the NHS faces significant pressures to improve patient flow and discharges out of the acute setting. At the Queen Elizabeth Hospital, within healthcare of older people, we often face difficulties and delays in discharges due to the pressures on social care in the community. And apart from those conventional harms of hospitalisation, such as infections and clots, frail older people are obviously at a much higher risk of this deconditioning. We've all heard stats out there, and we know that patients can spend as much as 90% of their time sedentary in hospital, completing less than 1,000 steps every day. So this is something that we're seeing at the Queen Elizabeth and something we're seeing in our cohort of patients. We know that activity supports quicker recovery and enables patients to remain independent and improve their overall health and well-being, which can then have a knock-on effect on length of stay and their needs on discharge. So if we're looking towards reconditioning, this is the process of restoring normal function following injury, disease, or inactivity. And it's everybody's business to try and maintain and restore normal movement and function in their patients. So this is kind of what I wanted to focus on today, is that it's not just a physiotherapy job, it's not just our role to be pushing this. We need to engage the wider multidisciplinary team at all levels, anyone based on our wards, to promote reconditioning. And I've got a nice quote down there from Dr. Aurora, who said that it's now time to move away from just raising awareness of deconditioning to establishing some reconditioning approaches to our work. On top of all of that, the World Health Organization defined patient safety as the absence of preventable harm. And now, what is preventable harm? Well, one of those things is hospital-acquired deconditioning. So by definition, we really should be trying to prevent this to provide patient safety. The image on the right-hand side shows some of the kind of knock-on effects of deconditioning syndrome, and you can see it impacts on a lot of body systems. So not just, falls, muscle weakness, but also cognition, increased confusion, disorientation, risk of pneumonia, risk of pressure sores, constipation and incontinence, affecting appetite, digestion, and leading to problems with swallow and subsequently aspiration pneumonia. And as I said, hospital-associated deconditioning is linked to increased length of stay, increased stress, and increased readmission rates. So it's something that not only in older adults, but all across the hospital, we should be trying to prevent. So with all of that in mind, like I said, last year, my team pledged to recondition the nation, and these are just some of the quotes that we had on our pledges. So how have we done this? Healthcare of Older People's mission to recondition the nation focused on 5 key areas. The first was training and raising awareness of frailty and deconditioning. We were trying to reintroduce ward-based exercise classes, roll out some MDT bed boards and patient information leaflets, and consider a novel Eat, Drink, Dress, Move student physiotherapy pilot placement. So we'll just go on to training and raising awareness of frailty and deconditioning. So we started off with training sessions on this topic delivered to ward staff, promoting discussion around the negative impacts of bed rest, ways in which we could reduce the worsening of frailty and prevent deconditioning in hospital, the barriers that we face when trying to implement some of these interventions, and any further ideas in which we could all work together to improve patient care. The training started by asking staff to fill out a questionnaire in which they considered their own knowledge at the moment of deconditioning and frailty, their current practice, and the barriers that they consider when moving patients. And then this activity was used to inform that discussion throughout the session, using the display board and a PowerPoint presentation alongside that. The training was really well received, and when asked to rate their knowledge and understanding of deconditioning and frailty before and after the training, most people saw an increase in their knowledge and understanding. So as a consequence of delivering this training and sharing its success, I've then made connections with a number of different departments to try and grow this as a training package, and try and address as many groups and as many disciplines of staff as possible to try and push that message out there that we should be trying to recondition our patients. So this has included a variety of study days within the trust and divisional rolling programs, some student education hubs and university education at university sites, and a collaboration with infection prevention control nurses to deliver training on the negative impact on infection control as a result of deconditioning. And I'm going to go on to a little bit more about an Eat, Drink, Dress, Move study day that we've recently piloted and had some really good feedback on. So Eat, Drink, Dress, Move is again another one of these kind of initiatives to promote just that, promote patients eating well, keeping hydrated, getting dressed in their own clothing, getting up and being as independent as possible in hospital. And this Eat, Dress, Move approach relies on the involvement of the whole team, and is really kind of being pushed by the trust across all of our sites. So the objectives of the study day were to allow staff from nursing and AHP backgrounds to understand a little bit more about these principles and the roles that we all have in optimising patient care together, to utilise the day to reflect on their own practice and ideas for improvement, to feel more empowered to promote the Eat, Drink, Dress, Move principles on their ward with their patients, but also with their colleagues, and have more confidence in being able to risk assess and safely transfer their patients. And overall, we wanted to try and increase and improve patient care and experience. So there are a variety of different topics that we delivered on the day, and a huge thanks to all of my colleagues that did support me with this programme. So we had topics on the role of dietetics, mouth care, the role of speech and language, the role of occupational therapy, dignity in care, continence, the role of physio, frailty and deconditioning, and the associated IPC risks. And then a practical element, measuring and providing mobility aids and safe mobility, and some case studies to practice using the elite risk assessment from a manual handling point of view. So these are some pictures from the morning sessions, delivering those topics that I've just mentioned. So we had a whole host of different speakers and some really good engagement. And these are some pictures from the afternoon, spending a bit of time in our therapy gym, getting a bit more practical and applying that knowledge. And at the end of the day, we asked everyone again to sort of make a pledge from what they'd learned from the day to recondition the nation and promote Eat, Drink, Dress, Move. These are some of the feedback that we got in terms of what staff would then do differently moving forwards. So a heavy emphasis on promoting those principles of Eat, Drink, Dress, Move, on mobilising patients, and on providing better mouth care. And finally, they also fed back that this study day could be delivered to all roles and of all bands. So it was really kind of helpful to get that feedback, that it doesn't just have to be AHPs that attend this study day. It doesn't have to just be nurses. Actually, medical staff could attend this as well, and all bands should kind of get up to speed with the Eat, Drink, Dress, Move principles. Overall, we had a really positive experience from those that attended, with 71% of 14 respondents scoring it excellent on their overall experience. Another way that we raised awareness of deconditioning and frailty was through our charity fundraiser in February, and this is where staff from Healthcare of Older People took to our atrium in the main hospital to cycle on a static bike up to 100k in the day. So staff took it in turns to have a go on the bike, and if they did, they got a medal and a certificate to say thank you for their involvement. And through that charity event, we raised £460, which the UHB charities match funded, and we had a total of £1,369.98 raised. And this was used to purchase some activities that we could do with the patients on the ward to kind of continue to stimulate them, to continue to promote kind of routine and activities during the day. Obviously, hospitals aren't the most stimulating places, and we wanted to try and use that money to spend it on things that we could use with the patients. So the next big kind of project that we wanted to run was re-implementing ward-based exercise classes. So during the pandemic, as I'm sure a lot of you are aware, classes and group exercise got stood down to adhere to sort of social distancing and infection control regulations. So classes for us would not only support our therapy caseload, but also improve patients' mental and physical well-being, maintaining strength and conditioning, and provide a social activity to participate in whilst in hospital. So reintroducing these classes really reinforce the promotion of patient activity, not only for the patients, but also for the staff on the ward. And it encouraged staff to get patients up and out of bed before lunchtime, because these classes ran between sort of 11 and 12 o'clock, which was a nice way to complete some exercise and leave patients sat out in their chair for lunchtime, so that they were eating in a better position and reducing that risk of aspiration whilst eating in bed. One of our student physiotherapists, Jasmine, used this to write up a little project. And she gathered some feedback from staff and patients involved in both the exercise class and then a lunch club. 100% of the patients that reported they enjoyed it and would attend again, and that the class was easy to follow. 83% stated that the lunch club improved their mood. And there are some other comments just there below. And 100% of staff enjoyed delivering the group exercise class and would recommend it as a long-term attribute to the ward, with benefits including that to mood, mobility, deconditioning risks. So staff also really enjoyed seeing patients smile and thrive in completing their exercises whilst playing music and interacting with other patients in the bay, which just highlights that positive impact that socialising and having a shared experience can have on both physical and mental well-being for staff and for the patients. And this is one of the testimonials from one of our ward managers, Wumi, which is just really lovely to receive after implementing those classes. As I said right at the start, from that workshop that I attended, I came up with the idea of a kind of movement board or a bed board. And so we started to trial these as well and roll these out. And after trialing it on a small number of patients' bed boards and getting some feedback from staff, we developed it into sort of a wider multidisciplinary team board to encompass more of those eat, drink, dress, move elements, and consider some of the other multidisciplinary team elements as well, from a dietetic point of view, from an OT point of view. We had some really positive feedback about the idea of a kind of movement board, and it was shared across social media and on future NHS good practice repository. So it is there for you guys to have a look at if you want. And we also got some really good feedback from staff and patients and relatives on the ward as well. So patient information leaflets, again, we put together kind of a eat, drink, dress, move, or movement matters patient information leaflet to really kind of inform patients about what it is that we're expecting them to do, and sort of empower them to do activity whilst they're in hospital. And this kind of caught the attention of staff over at other sites within the trust who wanted to pilot this as well and get some feedback. And the quote there is just one from one of the staff over at Heartlands Hospital who shared that with us after. And again, we sought feedback from staff and patients, relatives and members of the public. And it was all really positive, with some minor adjustments to make to the patient information leaflet, which is currently still in the process of going through our graphics team to be able to kind of mass produce this and roll this out on a number of different wards. The leaflets and the concept also sparked interest from therapy practice placement coordinators, who identified healthcare of older people as an ideal area to pilot an eat, drink, dress, move physio placement model, which I'll come on to now. So Solihull and Queen Elizabeth Hospital sites within UHB provided a different approach to clinical practice learning with the introduction of these eat, drink, dress, move student placements. And the aim of this placement was to provide students within their first year on their first placement the opportunity to develop skills in supporting functional activities, exercise and mobility with patients, which all feed into that eat, drink, dress, move concept. So a little bit of background on kind of the drivers for this kind of placement. Practice-based learning is a vital component of pre-registration physiotherapy education, and it can help to deliver education in a physiotherapy practice setting. We know that there's a shortage of placements nationally within physiotherapy, and there's various models out there to try and kind of suggest targets for different ICBs to meet. We know that UHB was under the aspirational target for placements. So we had to kind of consider a different way to increase our capacity, particularly for first placements, which were a challenge to fill. We also know that educators often feedback that students aren't always equipped with those basic skills required to work in an acute trust, particularly over the COVID pandemic period, where face-to-face and kind of that physical contact with patients was limited. And as this kind of whole talk is about hospital-acquired deconditioning, is a massive thing that we need to get on top of. So the two kind of issues combined led to us to consider how we could target both of them through a placement model. So like I say, the QE and Solihull sites provided this eat, drink, dress, move model, and I'll focus just on the QE where we did it. So we had 4 students with us at the time across 2 different healthcare of older people wards. So the total across those 2 wards was 48 beds on a 4-week placement. And like I say, the aims were to develop the basic skills in care and communication, supporting functional activities, exercise and mobility with patients on an acute ward. As well as that, it was useful to increase awareness of deconditioning and associated harms on the ward. And we did look at trying to increase the number of patients sat out of bed and dressed by lunchtime. So it was a very short placement. It was 4 weeks, and the first week was taken up by an induction week. So on the first day, students came onto their wards to kind of orientate themselves to the department, to the wards, introduce themselves to different members of staff that they would be working with, and just have that kind of induction and orientation to their workplace. For the rest of the week, there was a lot of lecture theatre teaching around topics that were relevant to the placement. As well as some self-directed learning, which the students went away, considered how to deliver exercise programs or one-to-one exercise programs, and then came back and fed back on the Friday. And then when they were with us, this is what a typical day would look like. Obviously, with the different demands during the day and during the week, this would vary, but most of the time, the students would come in early, work with the nursing staff to get a handover and support with breakfast, then work with the physios to establish what our caseload was, help to wash and dress patients and get them sat out as early as they could, and then they were ready for physiotherapy interventions. There'd be time for documentation and obviously for their lunch break, but around that they would support with meal times and further physiotherapy interventions, whether that was one-to-one or in an exercise class with a group. So before starting the placement, students, because it was so novel and it hadn't been done before, they weren't aware of it, their feedback was they didn't know what it was, they didn't know the structure, they thought maybe it might be a bit more around developing the softer skills rather than the clinical skills. There was some excitement, some apprehension. They knew that they would get to grips with the basic skills. As I said, we got the students to do a little audit whilst they were with us to capture the number of patients sat out of bed and dressed by lunchtime. And you can see that we were capturing the data before the students started, as well as whilst they were with us. And there was a steady increase in the number of patients sat out and dressed. So having those students with us in those kind of roles that were really promoting eat, drink, dress, move, and really preventing deconditioning had a really positive impact on those patients getting up and out of bed. So after the placement, the feedback was really positive from the students. They found it a very supportive learning environment, improved confidence and competence. Their knowledge of deconditioning improved and their appreciation for the complexity of older adults increased. And they did feedback that it would be great to have a longer placement, which was over 4 weeks, especially having that first day, that first week as an induction week. Unfortunately, only 3 of the 9 students in total across the 2 sites completed their feedback forms, but it was really nice to see that all 3 of those that did strongly agree that they would return to the trust, consider working in the trust and recommend the trust. off the back of this placement. So if we're thinking about recruitment and retention for physios in the NHS and in our trust, then this was really positive. And it wasn't just the students that fed back really nice things, it was the staff as well. So the staff found it really beneficial to have students promoting these principles on the ward and offering to help their nursing staff as well. So these are just quotes from matron and ward manager. So in terms of the next steps, we're looking to repeat this Eat, Drink, Dress, Move model at the QE in January, but I know at the moment there's a current cohort of students in Solihull that are repeating this. So we'll continue to kind of review it and feedback. We want to raise awareness of this type of model in other clinical areas to try and increase the amount of students that we can take. And the aim would be to roll this model out to all sites in the trust for all first year, first placement physio students. So looking back over all of the different projects that we've tried to kind of roll out and complete since the launch of the reconditioning games last year, we did capture sort of average length of stay across all of our wards over this period, and it doesn't necessarily mean that the things we've done have decreased length of stay, but it might be that some of this mindset and culture is starting to shift, and hopefully over a sustained longer period of time, we'll be able to see that length of stay does continue to decrease. And in terms of the success of our kind of projects and our work, this has been shared on a number of different platforms, from NHS Midlands Region First Learning and Sharing event as part of the kind of Recondition the Nation initiative, to the first episode of the Emergency Care Improvement Support Team podcast with Nick Holding, who I've been in touch with recently and would like to do a follow-up podcast. So we'll hopefully be sharing some more of our work on that. And I've also presented on the Global NPJ Paralysis Summit, and obviously today's Agile webinar. So all of these kind of platforms and events have been really, really lovely to share kind of my story, our story, and also hear from other people about what their kind of best practice is and what their success stories are. So I'd encourage everyone to kind of get out there on social media and follow different people, see what everyone's doing across the country, and take some inspiration from that to implement some things into your area. And it's because of these kind of platforms and the opportunities to share our work that we received a gold and platinum level award from NHS England and Midlands for our work to recondition the nation. As well as being shortlisted for the Staff Wellbeing Initiative of the Year and Improving Care for Older People Initiative of the Year within the HSJ Patient Safety Awards. If you do want to follow myself or our team HCOP UHB Twitters, then please do, and they're just on the screen there. And I was really proud to for our team to have been awarded a High Commendation Award for improving care for older people at the HSJ Patient Safety Awards. So this is a little snippet from our UHB connected sort of newspaper. So in terms of next steps, we're continuing to shout about preventing deconditioning at QE, and I really want to continue trying to push that to the forefront of everyone's mind, not just in older adults, but across the all specialities, because I think everyone in hospital is at risk of deconditioning. So we have started a frailty and deconditioning MDT working group, currently for seniors to kind of get together and consider some improvement ideas that can then trickle down to the rest of the team to sort of inspire some good changes and some good practice. Like I say, we're repeating the Eat, Drink, Dress, Move student physio placement model in January. From the success of the pilot Eat, Drink, Dress, Move study day, we're hoping to roll this out on a more regular basis and expand it across all of the UHB sites. 1 year on from our kind of launching our mission to recondition the nation, we are completing an anniversary challenge, which all of the wards are going to take part in, and has happened on one of our wards so far, which is what the pictures on the right hand side show. How far can patients cycle or walk in 5 minutes? So it's a challenge between the bays on the wards, or between each of the wards, to achieve the greatest distance with their patients within a set period of time, using our MotorMed cycle bike. And it's been really well received on the ward that we have completed it on, and heavily led by our assistant staff. So again, it's trying to empower different members of staff to kind of take the lead on really promoting preventing deconditioning. We've also had interest from our Pets in Hospital team, who want to do some joint physiotherapy sessions with our therapy dogs, and really utilise them to, again, prevent deconditioning and promote activity. One of my colleagues, Chris Wood, has really advocated to continue to deliver group ward-based exercise classes with Workout Wednesdays. So again, it's just getting the rest of the team now to take this message forward and to really promote activity on their wards. Like I say, we're just continuing to raise awareness of hospital-acquired deconditioning and shouting about our success stories. So just some top tips to finish up with. What I'd really recommend is branching out from your workplace network. It's really good to obviously speak with colleagues and see what everyone's doing within your workplace, but actually there's so much going on outside of kind of where you work that you could pull into where you work. So you know, join networks. Like, it's really great that you guys are all here as part of Agile, but the British Geriatric Society often have a lot of resources and a lot of different networks that you could learn from and get involved in. Find something that you're really passionate about, because that's going to be the main driver for a lot of your ideas. Get your stakeholder buy-in and engagement. So consider who you need on board with you and who's going to drive this with you. So think about the wider multidisciplinary team. Think about both registered and non-registered staff. So that could be assistants, support workers, healthcare assistants. And think about students and the future workforce and what you want to try and instill in them, taking forwards as they become qualified as physios. Make sure you establish your kind of overall aim and your overall theme, but give things a go and start small, think simple, try and work smart and not harder, and just don't shy away from shouting about your success and trying to reach those people that recognise it and spur you on to do more. And that is me. Thank you very much for having me again. And that's my email address there if you did want to get in touch about anything that we've done and find out anything more. But I think, yeah, I'm happy to take some questions and discuss a little bit further on here tonight.
Thank you so much, Jackie. What a brilliant presentation. Thank you for all the hard work you've been doing, and it's been a pleasure listening to you. So we've got a few hands. Shall we start with Naomi, please?
Hello. First of all, it's nice to hear from Jackie again. I highly recommend people go on the hashtag End PJ Paralysis Global Summit, which has her presentation as before, and also similar presentations. I like the eat, drink, dress, move in that order, and is a lot more polite and a good way of saying it than other presentations that say get dressed, get up, get dressed, get moving. It's very, very, you know, if you don't get up, you know, it's your problem. But eating, you have to get out of bed from, drinking, hydration, needing to go to the toilet, get you moving. And the things I'd like to think about as well is about getting families involved and making sure things are done over the weekends.
That's very helpful, Naomi. Thank you so much. Sophie?
Yeah.
You're on mute, Sophie.
Is that better? Can you
Yeah,
hear
I
me?
can hear you.
Yeah,
Yes.
thanks, Jackie. That was really inspiring. I work in the community, so see a lot of, obviously, deconditioning from hospital stays. But when I worked in the hospitals 20 odd years ago and we did exercise classes on the wards, it would just take forever to get all the patients into the room to start the exercise class. And so it just sort of petered off really because there just weren't enough staff members. So how do you sort of get around that?
Yeah, and I won't lie, it does happen. Things get stood down or kind of, yeah, deprioritized within our setting as well. I think it all kind of comes back to that engagement again and just really pushing for the wider multidisciplinary team to get involved. So whenever it is just like the therapy team trying to run these things, it won't ever work. You need the healthcare assistants that are on the ward at the time as well to feel confident to get involved as well, and sort of challenging them to perform their own risk assessments, feel confident to mobilize or even just transfer a patient out of bed is better than kind of leaving them lying in bed. So a lot of it comes down to just engaging, instilling confidence, empowering other members of the MDT to get involved too. We sadly we have got day rooms on our wards, but we don't tend to use them for exercise classes. We had started, we're quite lucky that we've got kind of 6-bedded bays or 4-bedded bays, so within the bay itself, keeping the patients there but getting them sat out and then doing seated exercises at the end of their beds,
as opposed to taking them all off somewhere.
Yeah. So that eliminates some of that time as well. We cover 7 wards and we don't have enough assistants per ward, so we have also tried doing kind of like, on this day we'll do this ward, on this day we'll do that ward, so that resource can be put into it, pulled from other wards to do it for that specific day. So I guess it's always trial and error, and there are things that are going to get that are going to take more priority than like a group exercise class. But you know, from the feedback we've got and the feedback we keep getting now that we're kind of trying to roll out more and more, it is so good for patients and so good for staff, that hopefully the more we do it, the more people see the value in it and the more that it will then be prioritized.
Thank you.
That's brilliant. Thank you so much. So I'll share a bit about my experience with doing a similar thing a few years ago. So I worked on an inpatient rehab unit and I had about 32 beds, and as the only physiotherapist on there, I had 1 rehab assistant and 2 part-time OTs. And what was happening was patients were coming from the acute setting and they were being told, you're going to go to this place where you're going to get physio every day. And so they would arrive and there is one physiotherapist. So how was I going to see all these 32 patients every single day and with the limited staff? So what I did was, one, I empowered the rehab assistant. I had one who was split between physio and OT. So I gave her the confidence to do things. So I taught her the seated exercise classes, seated exercises, and supported her a couple of times until she was independent. So she was able to run those. And then I used to run a balance exercise class in the gym. And then, so what happened was to move the patients to where they needed to go, like to the day room or the gym for the balance exercise classes. It was impossible for me to move those patients with the rehab assistant, just the 2 of us. So what we did was to engage the whole MDT, and the manager got to encourage the rehab assistants the care support, the support workers and the other staff to engage in that. So they got to know that it's 11 o'clock and no, it was 10 o'clock. So when it became 10 o'clock, everyone would start moving around. So if the support workers were with the patient, they would start telling them, you need to start walking to the other room. And then the patients, you'll have some patients who are a bit mobile. So then you can go with a couple of them. Those who don't need a lot of support, you can walk with a couple of them then rather than walking one at a time. And so that helped quite a lot. Just that whole MDT engagement, like Jackie is saying. So yeah, if you can try that, that might help. And I think there was a lot of good feedback, just like the same as Jackie was saying. The manager was so happy. The patients were less depressed. There are those who want to hide in their rooms. So suddenly they are the ones who are reminding the support worker who is helping them with washing and dressing that you need to hurry up because we need to go to the exercise room. So really, when you start the culture, it does get embedded and it makes it easier for you. Della, thank you for waiting. Please come in.
Oh, hi. So I work on a frailty unit at North Manchester, and really excited to hear about the initiative, and yeah, definitely looking at like the student placement. I was just wondering whether or not the students were made aware of that, like they had an option of it, or whether or not you just said that was the placement, because obviously it is moving away from traditional physio placement, but you know, obviously same challenges as everybody else. You're looking at trying to, you know, maximize the amount of students that we're taking. So I just wondered what the challenges were, because like your data was good for the ones that gave the feedback, and just wondering, was it that the other ones weren't happy with the placement, or was it just that they weren't very good at the paperwork at the end? So yeah, it's just obviously moving away again, which obviously universities are prepping them for. You know, there's other placements that aren't as hands-on, so at least they're getting that, you know, patient contact and all those skills that you need. So yeah, I just wonder what the challenges were with that.
Yeah, really good points. I don't think they got much information about what they were coming to, and I think in terms of the amount of information that the university give them, I don't think it's very much at all in any kind of area that they're going into. I think for those students, so these are Birmingham Uni students, and I think they got, you know, they get like a allocated, and it's just like a line to sort of summarize what they're going to do. Obviously, being such a novel model, they won't have known much at all. So I think we were considering how we could get more information to the next kind of cohort in the future, because that is what they fed back, that they didn't know what this was going to be. But it was because of that kind of like induction week at the start, and the main feedback we got about the induction week was that it was too long for such a short placement, and they'd rather have kind of squeezed that into maybe a couple of days. But at the same time, they did feedback that it was actually really helpful, and all the topics covered in that were helpful to then kind of align expectations for what that placement was.
Sorry.
So we did kind of consider whether we could almost get the universities to sort of deliver that stuff before they then came on placement with us, but again, it's all kind of still work in progress. In terms of the feedback, so we ran a feedback session right at the end, and that's how we captured some of the more the narrative rather than the feedback form stuff from all of the students, and they were all really positive about it, and they were quite keen. I don't know if we just got a good bunch of students, but they were quite keen to stay in touch and kind of continue to promote that kind of placement for future students. So kind of first-hand accounts of how they found it, which was really nice. But they probably, we sort of said to them, they probably won't realise the the advantage of having a placement like this until they've gone on to a couple more placements and realised actually, yeah, it was really helpful that I had for my first placement in my first year, I had the opportunity to just get to grips with moving and handling patients and promoting that functional activity on the ward, because I can see how that is important on this next placement and this next placement. So the idea hopefully is that we can get back in touch with those students now that they've been on a few more placements and get some more feedback about what their thoughts are on that kind of model. But yeah, like with all, you know, there's like leadership placements now and kind of long arm placements and all the kind of different models out there. It's always going to be difficult to kind of manage expectations for the students. And one thing that I would recommend is getting, again, buy-in from your MDT so that they know what the expectations are as well. Because at the beginning, it was very much like, oh, you could be a second pair of hands for the nurses kind of thing. And so the students had to be quite strong and confident to say, actually, no, I'm here to support with those functional activities, but I'm a physio student. Which luckily, again, we had a good cohort of students that were confident and felt empowered to be able to say that and kind of align expectations from the start.
So did you have like objectives for them to meet so that they were aware of kind of how they were working, you know, within the remit of physio? Because it, like you say, it will just end up being a second pair of hands and almost a nursing kind of, you know, placement. So I guess it's just making sure that that focus is on physio still, isn't it?
Yeah, and I think the students should be coming with their sort of university set objectives for their first placement as well. So it's aligning them with what you're expecting them to be doing within that placement model. And it does match up quite nicely, or it did match up quite nicely. I think we're just going to have to keep kind of reviewing it the more cohorts we put through.
Great, thank you.
Thank you very much.
Can I jump in just for 1 minute before we take any more questions from the board over here? Could I just, there are a couple of questions in the chat, if I could just read those.
Sure.
So first of all, there's a lot of positive feedback already to your presentation and what you have kind of shared with everyone. There's a question here about from Louise saying, could I see the version? I think she was talking about the blaze pods on the equipment that you purchased after the charity event, and just checking if they were the cheaper version or the originals, because she is looking to buy some of those. So just a little bit of what you have bought.
Yeah, let me just find what pieces of equipment, sorry.
Yeah, the blaze
was it
the blaze pods, I think that's what.
like the stairs and things, therapy room.
Hi, can you hear me?
Hi, yeah.
Hi, sorry. You had a picture of a lot of equipment that you bought after your charity event, and it looked like you had blaze pods, which are the little circular things that they put lights on them, so the patient has to touch them when the light goes on to work in the balance. It looked like blaze pods. Were they blaze pods or were they something else?
No, there might be the buttons. They are.
They look like coloured buttons, which are normally called blaze pods. Is that what they were?
No, I think they are. Let me try and share this. Sorry. Is it the?
I have lost my screen for some reason, so I'm not sure I'll be able to see.
Oh no. Well, so I'll tell you what we did have. So we had some signs for stairs and therapy room. We had some playing cards, some puzzles. It might be the coloured sand timers that you were looking at. So we had like.
I think from the picture, from what I remember, I think it was to the right of the sand timer. There was something circular to the right of the sand timer.
Yeah, the circular thing. So they're talking clocks.
They're not blaze pods. Okay, fine. Thank you.
Yeah, no, just clocks.
And And I think there was another question from Ruth about the group. I think you mentioned about a group that you are planning to create with the senior therapists in your hospital. And I think the question was around, could you provide information about, mentioned about joining a group, could you please provide information? So I think it's just about that group. Please correct me if I'm wrong, and jump in. Ruth, if you have raised that question.
I'm trying to scroll up to read it, but so the frailty and deconditioning working group that we're setting up is just within our healthcare of older people team, and it currently opened it up to the geriatricians, the consultants, ward managers, matrons, and then the senior physios and occupational therapists, just to bring everyone together to kind of review how the last year or so has felt, get some feedback on kind of the barriers that we continue to face when trying to implement sort of change, and come up with a few kind of key ideas and work streams from that to sort of maintain momentum with these kind of projects. Again, like I say, it's just trying to get that MDT buy-in. So the idea is that if all of the seniors are singing from the same hymn sheet and sending the same message out to the rest of their team, so their medical team, their nursing team, and then our therapy team, actually, hopefully we'll see a little bit more collaboration moving forwards, and a few more ideas coming within that kind of frailty and deconditioning kind of topic. But in terms of groups outside of kind of my area, my hospital, the British Geriatric Society is a really good society to join, and within that there are sort of special interest groups, so there's a lot around sarcopenia and frailty. You've obviously got the Chartered Society of Physio and Agile, but get onto Twitter. I didn't have Twitter up until a couple of years ago, and there is so much out there, so much good resource, like links to other webinars, links to other resources, up-to-date guidelines, policies, just everything. If you search for things on there, I find Twitter really, really helpful, and it's how I've been able to kind of shout about what we're doing, and then other people can see it and they'll shout about what they're doing, and I'll get ideas from them and make those connections. It's a really good place to kind of network, I've found.
Thank you very much. I think we have about 4 minutes remaining, so maybe last couple of questions and then we can wind down. Thank you very much.
Thank you very much, Rachel. Arinze, do you want to come in, please?
Thank you. Good evening, all. Thank you, Jackie, for the presentation. I wanted to ask, is there a way to imbibe this dream and drive with new starters in your trust? Because it seems like, in as much as it's linked to your team, but is there a way, because sometimes dreams like this die off over time, so that, just like you said, keep spreading the word. Are there mechanisms in place, if kept, especially for new starters in your trust, with regards to this training? Thank you.
Thank you. Yeah, really good kind of point and really good question. So when I've approached people about getting this kind of topic into sort of mandatory training, so that everyone has to redo it, like we do with fire training and information governance and things like that, I'm always kind of met with a lot of resistance and a lot of, well, it takes a long time to get anything onto kind of a mandatory platform that everyone has to do. So how I've gone about that is trying to provide this study day, which like I said, has been really positive and has some really good positive feedback. So I'm hoping that by doing that and taking that feedback, we can roll out a lot more of these study days across a lot more sites to capture a lot more people. So there isn't anything at the moment for new starters coming in, but that, exactly like you say, it's trying to get it out there to as many people as possible and sustain that that message. And I think through, you know, platforms like this as well, hopefully kind of you guys can go away and consider how that might work in your workplace too. But also just, yeah, trying to do as much as I can to spread the word on the platforms that I've got is where I'm at the moment. But I think you're absolutely right. It does need to be made a priority for kind of all specialty areas, not just healthcare of older people, all AHP disciplines, all nursing, all medical, and yeah, particularly getting people sort of engaged from day one as a new starter or as a student, to kind of keep carrying and pushing that message forward.
Thank you very much, Jackie. This is going to be the last question. So, Georgina, please. We can't hear you, sorry.
Okay, does that work?
Yes.
Great. Okay. My headphones weren't working that well then. Sorry. Jackie, thanks so much for your inspiring presentation. I've been following you on Twitter and it's been a joy to listen to all the amazing stuff you've done. We have been trying to enact a kind of frailty model and a healthcare older people type model in our hospital in Oxford, in our medical wards. That's meant that we've had to move from a kind of discharge planning kind of helpful, try and get people out of hospital, to a deconditioning or reconditioning kind of model. I wondered if you had any top tips on how, if you've had to do that journey, if you've had to move from being focused on getting people out of hospital to focusing on how do we enable them so that they don't decondition too much and therefore need more care and need more equipment and everything else. Any inspiration?
We haven't really, well, I say we haven't had to. We haven't tried to move to that kind of preventing deconditioning way of working, purely because of the demand and the pressures and that constant churn to get patients out of that acute setting. So I admire you for being able to attempt to, and I can appreciate that it's probably been quite challenging with that constant pressure. I think more focus needs to be put on reconditioning being a priority, because it is going to have a knock-on effect. It won't be instant, but eventually it will have a knock-on effect, and that's why we need everybody engaged. I think within the MDT, you've got, you know, the medical team that are so medical focused. You've got the nursing team that are, you know, they've got drug round after drug round, and they've got this person calling. So and then you've got therapists that are trying to drive this preventing deconditioning, but actually it should be everybody's priority because it has a knock-on effect on everybody's roles. So again, it kind of just comes back to educating and engaging and empowering everyone to push that message and to try and promote those things. I think I don't know if you have tried like group exercise classes, or have you tried what sort of different ways of working have you kind of implemented?
So we haven't tried group exercises yet, but that's the kind, we've only really been starting like the last 6 months or so. Okay, so
yeah,
what we did was we've separated out a set of staff whose job it is really only to do patients who have the major frailty syndrome, so UTI, if they come in with a delirium or a fall, or they're post ITU, or they've just reduced mobility. We hone them into a particular part of our therapy team whose job it is simply just to quickly get there, see them on day one, rather than what can happen is this person's medically fit to go, so you need to see them now, and so that's how your caseload gets prioritized, that you only see the ones who are going today and you can't get to the other ones, so nobody gets any rehab. So we basically protected half of the team to only deliver the rehab, to stop deconditioning, and trying to gather some data to be able to show what the benefit of that is. But of course, we haven't been going long enough to really be able to show enough yet. But you can only run a team like that for so long before you feel the divide and the pull of the two different visions. One is pushing for, we've got to get patients out for discharge, and one half is effectively being protected from that, and doing lovely rehab and all the wonderful things that you've been talking about today. And we need to somehow, at some point, we need to bring the teams back together. But it's a real, it's quite, they feel like those two visions pull against each other. And I just wondered if that's a thing that you face. How do you make sure you have time to do all the things that you're talking about? It's quite inspiring.
Yeah, I think that's something that I've considered in terms of having like more of a rehab team within the team, and I considered kind of using the clinical frailty score to prioritize the rehabs. Obviously, you've got your red priorities and your medically fits, and you've got to get them out, but then within your lesser priorities, reprioritizing them based on the clinical frailty score. But that relies on the clinical frailty score being done and done accurately. So I've kind of faced barriers with that, but it's, again, it comes down to shifting mindset and culture, which is just so incredibly hard. And you have got to just chip away at it. And yeah, I think platforms like this and all the stuff on Twitter does kind of spur you on to keep going. Like I'll hold my hands up and say sometimes it just feels like way too much. I'm not making any change. I'm not seeing it like positively play out, but you almost need to, it needs to be difficult, and you almost need to say fail, but you're not failing at all, but to see how to make it better, make it easier. And that's the only way that you're going to evaluate. You're never going to get things right the first time, so try it like you are, get feedback like you are, and just keep going with it. Like the end goal is always going to be the same. Like everybody on this call wants to help prevent deconditioning. Everyone nationally, there's a big drive. Chief Medical Officer's put out his paper about improving care for older people, and the right to rehab and everything is in there, and the government are seeing that, and it is a priority now. So we've just got to keep going, and it's so hard. It's so hard. I admire everyone for trying at least something small, but that's all you've got to do. Try something small, and just keep evaluating it, keep shouting about it, get everyone on board with you. And yeah, I'd be really interested to see how you get on, because I think that's really, really good.
Great. Thank you so much. That's great.
Thank you so much. So our time is far gone. Thank you so much, Jackie. I think just a small comment to add to Georgina's question. So there's a leader I follow, and he says leadership is influence. So when you have a goal, when you have something you want to put across, it's thinking about how to influence people. And I think another tip I've learned on my leadership journey is when you go to a leader, like your manager, with something you think they might oppose. So if you have something and you think there are some people who might not buy in, or who might struggle to buy into it, you need to go with potential solutions for what they might potentially say is the problem, why you cannot implement what you're suggesting. So think about what they might say against your project or your idea, and then go with solutions. So you go with your idea and then solutions to whatever problem they might highlight. And then that way they will sort of say, okay, you go and try. Let's see how it goes. And then once you have the go ahead, then you can, like Jackie has said, you keep evaluating, you keep getting feedback and seeing how to make things better. So I am going to say thank you so much, Jackie. Thank you everyone who has asked questions. This has been a very inspirational, very engaging talk. We are really, really grateful. And I know we've all taken away something that we can implement in our practice as MDT members, wherever we find ourselves. So thank you so much. Big thanks to the East Committee. Thank you for all your input into this. Ritu and everyone else. Thank you. And thanks everyone for being here. We're really, really grateful and we look forward to seeing you again. Have a good night. And for those who want the recording, it will be put on YouTube and it will be sent out. The link will be sent out to you via our broadcasting channel. So thank you.
Thanks, everyone.